Characteristics of inflammatory bowel disease, shortened to IBD.
Hey, what are you doing here?
Hey, I'm here for a checkup with my gastroenterologist.
Oh, is something wrong with you?
Yes, I have IBD.
I've never heard of it before. Could you explain what that is?
It's inflammatory bowel disease. It causes chronic inflammation of my colon and a lot of discomfort.
I'm sorry to hear that. Could I join you inside?
Yeah, no problem, just follow me.
So how long have you been suffering from IBD?
I've had it for 2 years already.
And how did you find out?
Well, I had abdominal pain and I was losing a lot of weight. And I went in for a visit to my doctor. I did some blood work and other analysis, and my doctor said I have IBD.
How is your disease treated?
Well, my doctor is giving me state-of-the-art anti-inflammatory medication, but it's not curing the disease, and I still suffer from it. And I don't think the treatment is working for me. And this is my doctor's office, and I'm going in. I don't think you can come along with cameras, so goodbye.
Good luck.
Thank you.
My name is Pim J Koelink, and I'm a researcher at the Amsterdam Medical Center, and my research involves inflammatory bowel disease.
Could you explain what are the main characteristics of IBD?
Well, the main characteristics of inflammatory bowel disease, shortened to IBD, is that patients with this condition, they develop intestinal inflammation, which causes a severe reduction in their quality of life, because the patients are getting fatigue, so they're getting tired, and they're having a lot of pain in their bowel. So this is really a problem for these patients.
What is the cause of IBD?
Well, largely the cause is unknown. It's thought to be a mix between genetic makeup of the patients and environmental factors like bacteria that are present in your bowel.
How are IBD patients treated?
Well, a lot of these patients are actually effectively treated with anti-TNF therapy. So this is so we have an overproduction of TNF, which is an inflammatory cytokine in the intestine, and then we apply antibodies, anti-TNFs, and those are called adalimumab or infliximab. And actually a lot of patients really respond to this therapy, about 70%, but about 30% of the patient does not respond to this therapy.
Why do some patients not respond to this treatment?
Well, as a fact, that's currently unknown, but one of the general hypotheses is that these patients, they actually produce a lot of proteases that are capable of degrading the antibodies. So if you have the antibodies, infliximab or adalimumab, present in the human body, there are proteases, mainly the MMPs, and they are able to cleave these antibodies, and then you get just fragments of the antibody, and those fragments cannot be effective in the body to reduce the disease.
Because we know that non-responsiveness to IBD therapy can be caused by cleavage of the antibodies by MMPs, we want to design an antibody that is resistant to MMPs. So we make a mutation here, and then in the first experiment we will add MMPs to either the normal antibody or the MMP resistant one that we created, and we will check to see if indeed less antibodies are processed by the MMPs. Then we'll use PBMCs and add either the normal, the regular antibody, anti-TNF antibody, or the MMP resistant antibody. And then we'll measure the T-cell proliferation, apoptosis, and induction of type 2 macrophages. To study this in vivo, we can use a rag knockout mouse, which doesn't have T or B cells. And then we're going to do a T-cell transfer to induce chronic inflammation in these mice in the intestine. And then we treat the mice with either the regular antibody or the MMP resistant antibody. After sacrificing the mice, we'll look at the response to this anti-TNF treatment by measuring the cleavage of IgGs, intestinal inflammation, and the differentiation of regulatory macrophages. If our hypothesis is correct, using MMP-resistant antibodies in IBD could improve the anti-TNF therapy.